Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
Hi, and welcome to this program, From Approval to Practice, Expert Approaches to Infusion Site Reactions in Parkinson's Treatment. I'm joined today by my colleagues, Rajesh Pahwa, who's professor of neurology at the University of Kansas Health System, where he's the director of the Parkinson's Foundation Center of Excellence, and by Jennifer Huey, who's a clinical professor of neurology at the Keck School of Medicine at USC and co-director of the residency training program there. I'm Dr. Stuart Isaacson, director of the Parkinson's Disease and Movement Disorders Center of Boca Raton. Our agenda for this short program is the clinical use of some recently approved continuous subcutaneous medications for Parkinson's disease. We'll give some expert recommendations for addressing infusion site reactions, or ISRs, and talk a bit about patient communication surrounding these ISRs, and we'll have some time at the end for a couple of case presentations. To begin, Dr. Pahwa, will you take us through some of the information on why we desire subcutaneous therapies in Parkinson's disease?
Yes, thank you very much, Dr. Isaacson, and thank you for having me here today. One of the challenges that we have had with Parkinson's disease has been having the right treatments for the disease. We have had some real major milestones in the treatment of Parkinson's disease, which included levodopa, still being the most effective and the gold standard treatment of Parkinson's disease. This was followed by deep brain stimulation, which also helped a significant number of patients and continues to do so today. I think we have reached the next milestone of treatment, which is continuous subcutaneous therapy in Parkinson's disease. So why do we need continuous subcutaneous therapy? Well, we do know that long-term treatment with levodopa results in motor fluctuations. And by motor fluctuations, we mean time during the day when the patient is on, when their medications are working and they're doing well, and times during the day when their medications are off, when they have more of the Parkinson's symptoms. We believe patients develop these motor fluctuations due to multiple reasons, such as the short half-life of levodopa, which is only 90 minutes. In addition, there's loss of buffering capacity of the dopaminergic neurons in the brain, as well as the challenges through GI absorption of levodopa. Remember, levodopa is absorbed in the small intestine. There is delayed gastric emptying in Parkinson's disease. So until the levodopa makes into the small intestine, levodopa does not quite begin its journey to the brain. So that's another challenge why patients develop motor fluctuations. Providing continuous subcutaneous infusion therapies, we can provide stable levels, and these stable levels of their medication would, we believe, reduce the off time as well as improve their on times during the day. So currently we have 2 subcutaneous infusion therapies available and approved in the United States. One is fos-carbidopa, fos-levodopa. This was approved by the FDA in 2024 and is indicated in the treatment of motor fluctuations in adults with advanced Parkinson's disease. It is the first and currently only levodopa-based subtherapy. Phoscarbidopa and phoslevodopa are the prodrugs. They go into the body and become carbidopa and levodopa. The second one is apomorphine. Apomorphine, as an rescue on demand as needed therapy, was approved back in 2004. In 2025, it also was included as a subcutaneous infusion therapy for the treatment of motor fluctuations in adults with advanced Parkinson's disease. Subcutaneous apomorphine infusion has been used for decades in Europe and has just now made it into the US market. So, two pumps that are used for continuous infusions. They are both applied to the skin and basically applied wherever there's subcutaneous fat present. The application is very similar with the two infusion sets. One, as I said, provides phoscarbidopa, phoslevodopa. The other one provides apomorphine continuous infusion, both relatively easy to use and small in size. Majority of the patients, as you see, do very well and don't have skin reactions. But later on, we will show you cases in patients who actually end up having reactions or can have reactions with these. So, what are the differences between these two subcutaneous infusion therapies? Well, with apomorphine, this is used as an adjunctive therapy. Just like other dopamine agonists, the dose is gradually titrated up, and if possible, the other medications are gradually titrated down. It's rarely possible to end up with monotherapy. However, 5 to 10% of the patients may end up with monotherapy. On the other hand, with phoscarbidopa, phoslevodopa, we are replacing their oral carbidopa levodopa with the phoscarbidopa levodopa. Hence, if the patient is not on too much adjunctive therapies, it is possible that the patient may end up with just the infusion as their monotherapy. How long do we use it? Well, the apomorphine infusion is approved for 16 hours during the day. However, we can use it up to 24 hours as an off-label use during the day. Often we may use lower doses at night, but we don't have to use lower doses at night. On the other hand, with phoscarbidopa, phoslevodopa, it is a 24-hour infusion. Although some patients may opt for just daytime, which would be 16 hours, and some patients may want a lower infusion at night, especially if it affects their sleep or causes other issues. But most of the patients just stay on the same infusion rate for 24 hours. As far as clinical efficacy is concerned, both of them in clinical trials showed very similar improvement. Apomorphine was an off-time reduction of 1.9 hours, and on phoscarbidopa, phoslevodopa, they looked at the on time, which is usually the opposite of off time, which was 1.8 hours per day. Now, one point to remember is apomorphine, the trials were done versus placebo. In phoscarbidopa, phoslevodopa, the trials were done against oral carbidopa, levodopa. If you look at the long-term efficacy, and we have data up to 1 year, again, the results were very similar at 1 year in an open-label fashion. Apomorphine, you had a 3.7-hour reduction in off time, and phoslevodopa, you had a 3.8-hour improvement in on time. When you look at the clinical experience between these two, like I mentioned earlier, apomorphine has been available for decades. Phoscarbidopa, phoslevodopa is new. And like I mentioned, the nighttime use of one versus the other. So one of the challenges with subcutaneous infusion, of course, are the skin issues that can occur. And if you look at the long-term data and look at the skin reactions that are seen with these infusion, if you look at apomorphine, the most common is skin nodules. And the other side effects that were seen were somnolence and nausea during the initial titration phase. On the other hand, phoscarbidopa, phoslevodopa, it included cellulitis in 23% of the cases, abscesses in 11% of the cases, and hallucinations in 17% of the cases. When you actually look at what these infiltrates show, and again it differs, with epomorphine it's more eosinophilic, which is more like a skin reaction, as opposed to phospholevodopa, which is more lymphocytic and neutrophilic, which suggesting more likely an infection. Most of these skin reactions occur early, but they may definitely persist with repeated use. With that, I will turn it back to Dr. Isaacson for the next part.
Well, that was fantastic, Raj. Thanks for bringing us up to date on these two new therapies for people struggling with motor fluctuations. These infusion site reactions have been of concern to some, but I think we really have to understand what it means because I don't find it concerning. We need to be aware of them, we need to understand them, we need to educate our patients about them. But it's no surprise that when something is given beneath the dermis, in the space that we call subcutaneous, meaning beneath the dermis, so they can be absorbed in the blood vessels at the base of the dermis. This dermis is about 5 to 6 millimeters thick in all people, large and small. And the Teflon catheter that's used in these infusions goes through the dermis in a perpendicular and delivers the medicine just beneath the dermis so it's absorbed in those blood vessels. And then when it's removed after the 16 hours of the apomorphine infusion, or the 24 hours or to 72 hours, depending on how long it's kept in for the carbidopa phospholevodopa infusion, there's a little bit of medication still in that spot beneath the dermis. And the body's immune system recognizes this foreign substance and activates the immune system, the inflammatory system, to get rid of it and send in inflammatory cells that can take it up and disperse it. Sometimes this just happens and we're not aware of it. Sometimes there may be more of an inflammatory response. Maybe more medicine was left there. Or maybe someone was having more stress or adrenaline flow or having some type of other allergic reactions to other things, seasonal allergies. And maybe for some reason the immune system is a little bit more activated and you might feel beneath the skin a little bump, a little nodule. And these are the most common infusion site reactions, these nodules that are asymptomatic and felt beneath the skin. Sometimes over a day or two, inflammation might increase and you might see a little redness on the skin. Sometimes it could itch. Infrequently, it might increase over the next day or two and become more red, a little warm, a little bigger, and then subside. But we always fear, well, how do we know it's not an infection? Well, infections should be uncommon because this is a closed system, but they could occur. And we saw them in the phospholevodopa, phoscarbidopa development program, although they were not seen commonly in the apomorphine infusion programs. So how do we distinguish inflammation that is common and expected with subcutaneous infusional therapies from infection? Well, inflammation tends to gradually increase over time and tends to subside by itself. It's self-resolving. Typically, it's asymptomatic. Mostly you don't even notice anything, but when you do see something, if it increases over a couple of days, it should come back down over a couple of days as well. If it seems to be increasing, if it's associated with fever, fluctuance, signs of cellulitis, then we have to suspect, could there be an infection? So if it continues to increase over more than a few days, we have to worry about that. Sometimes there might be something that can be cultured. Sometimes it's an empiric diagnosis and treatment. Most often we observe and we recognize and reassure our patients that they should move the cannula site. Don't put it in the same area where you see an inflammation or edema. If it's a small nodule, maybe don't put it exactly where you feel the nodule, put it to the side or somewhere. Some people find and suggest that not only to cleaning the skin beforehand and maintaining skin hygiene, but also when you take out the cannula to make sure you clean the skin so there's no irritation on the epidermis. And then if there's some more erythema that's occurring or inflammation, to regularly massage the area, either with the finger. Some people have suggested a spiky ball, and some people have used an electric massager for about 5 or 10 minutes to sort of disperse that medication that's beneath the dermis so that it can be dispersed more so you won't get an accumulation of inflammatory cells. And I also think that if there's a certain area on the body that a patient finds tends to provoke an inflammatory response more commonly, to avoid that area. Some people have used not only an electric massager but an ultrasound uh, to the area, and this has been shown in some small trials. When do you want to be more cautious and maybe pause therapy for a day or two, or avoid that area? Certainly. Well, that would be if you think the site reaction is more moderate to severe, if you suspect an abscess formation, if you think there's drug infiltration or pooling, you want to remove it and move it to a different area. But recognize that these subcutaneous therapies are places where it's reversible, it's taken out, and infections are uncommon but can occur. This chart here gives the idea that observation is the first step and most common. Manual therapy of trying to disperse the fluid that's left behind when the cannula is removed. Empiric therapy, if you're concerned about recurrent inflammation, maybe an anti-inflammatory could be useful, an antihistamine if you're concerned about an allergic reaction, and empiric antibiotics, if culture can't be done, can be used as well. So I don't think we need to fear this. We treat this as neurologists, much like we now treat things like constipation and such, that this is most often self-limiting and self-resolving. We've proposed a clinical framework for managing these subcutaneous infusion-related infusion site reactions, where patients need to be educated. We're going to talk about this in the next section on the importance of skincare, of rotating sites, of taking it out every day. And then if it's, although with the carbophospholipo, you can leave it in for 72 hours, we often start with a 24-hour change and then work our way up if it's tolerated. Getting history from a patient on the timing after the infusion, when the cannula is taken out, the location, if there's itching or pain or redness, warmth, and examining them if we can. We often have patients take pictures of these. And we might think about classifying these as asymptomatic, or perhaps we see some erythema and then maybe symptomatic and mild. Maybe it might increase over a couple of days and be moderate. It usually subsides by this point, mild to moderate. But if it were to increase, we might consider empiric antibiotics. So let me just ask Dr. Yui to maybe take us through how she talks about these with her patients and approaches this so patients are aware and informed.
Great. Thank you very much, Dr. Isaacson. So now we'll just pivot to best practices on how to communicate about infusion site reactions with our patients who have started these therapies. First, it's vitally important to set expectations on the technique of inserting the cannula, both with regards to anatomical site and aseptic technique. The site of insertion should be in an area with adequate adipose tissue and generally at least 2 inches away from the navel, joints, folds, hardened skin, or scars, or any area that might be irritated by clothing, such as belts. We can't emphasize enough the importance of aseptic technique, washing hands before changing infusion sites, avoiding touching the exposed end of the infusion line or cannula, and using an alcohol pad to just wipe the area widely. We don't have a lot of evidence-based data on how frequently to change sites, but longstanding experience from insulin pumps suggests that more frequent site changes, such as every 1 to 2 days, might minimize infusion site reactions. Additionally, it's generally recommended not to use the same site within 12 days and to alternate left and right sides of the body to avoid sites that are close to previous sites. Typical sites of insertion include abdomen, flank, upper thigh, but more remote sites such as the upper back can also be used. Finally, there's a general shift to using a longer cannula, 9 millimeter versus 6 millimeter in the case of phospholevodopa, in order to minimize drug pooling and superficial irritation due to the infusion liquid itself. It's important to remember that infusion site reactions are common and perhaps even expected as a result of these subcutaneous infusion therapies. As you heard from Dr. Isaacson and Pawa, there are some differences that we can discuss in the upcoming cases, But remember that most reactions are mild to moderate and can be treated with conservative therapies or, if necessary, short courses of antibiotics without interrupting therapy itself. We do have some more clinical experience with the subcutaneous apomorphine, but definitely gathering more data about the long-term tolerability of phospholevodopa as we gain more familiarity with its use. And finally, the appeal of subcutaneous therapies is that they are reversible and flexible in terms of dosing and a real good alternative to patients with motor fluctuations, either as a bridge to surgical therapies such as DBS or for patients who are not otherwise surgical candidates. So when should you contact the neurology team? As with all infections, if there's a sudden swelling, fever, drainage, worsening pain, or symptoms that are not improving or actually growing over time, over more than a couple days, and not improving with conservative therapies such as massage, that's the time to consult your healthcare provider. More unique to our PD therapies is if there's a noticeable change in the efficacy of the medication, such as morning akinesia or decreased on time. This could mean that there's pooling or extravasation of the drug into the subcutaneous space where the drug isn't really being properly absorbed. Occasionally, there's evidence of liquid emanating from the puncture wound as evidence of this pooling. Regardless, it's really important to keep in close touch with all your patients getting infusion therapies, both for dosing purposes and for side effects such as skin reactions.
Well, that was great. Fantastic, Jennifer. What a great overview of how we keep our patients informed. Raj, do you want to present the first case so we can maybe take some of our learnings and apply it to patients?
Yeah, definitely. So the first case I'm going to present is a 70-year-old male who was diagnosed with Parkinson's disease about 13 years ago. And before I actually talk about this case, I want to point out certain features. One thing is we do educate our patients when we start the infusion, what to look for, and when to contact us if things change. So that is an education that's provided so the patients are aware of it on what to do. So this patient was experiencing off time, was on oral carbidopa, levodopa, as well as amantadine DR, ER at night before surgery. Before the infusion was started. Once the infusion was started, we used a 9mm cannula because that's what we kind of prefer using. And we initially recommending changing it every 3 days as far as the set was concerned. On day 30th, he reported marked improvement and reduced off time and dyskinesias. He called back in about 10 days telling that he has had some redness and pain on his infusion site for the past 2 days. However, there was no fever noticed. So when we started, we often tell the patient to keep a watch. If there's a little bit of redness, just to keep a watch on it, not to let us know. But as the redness gets worse, or if they start having pain, to contact us. Once they contact us, we usually recommend they send us a photograph. And this is what he sent us. What we tell them at that time is to draw a circle around this lesion and to watch it for the next 24 hours and see if it is getting better or worse. As long as the patient didn't have any fever or any systemic symptoms, we just recommend watching it. What happened is over the next 24 hours, the patient felt that the pain started getting better, the redness started getting better, and we really actually did not even recommend using anything for this patient, and it really improved spontaneously. Of course, if some patients are concerned, we do tell them to use maybe a local cortisone ointment or a local antibiotic ointment. I don't know, Stuart, what you would have recommended your patient, but this is what we did, and fortunately, we had a really good outcome.
Yeah, I agree. I think these are usually self-limited. We would not expect an infection. But if we're concerned, then we use empiric antibiotics. But we expect this to improve. This is more than we typically will see regularly. I would say if somebody has this, I might see this once every month or two. But I would recommend to this patient to continue the 9mm cannula. Indeed, if they were using the 6mm cannula, I would switch them to a 9mm. I think 9mm should be used routinely, but I would change them to changing this every day. instead of every 3 days, with the idea that there's less medication going to a particular area to elicit this type of inflammatory response. Again, this is just inflammation beneath the skin, and we want to minimize this. And I would ask them also to maybe avoid that area and to use areas more to the side or below it. Jennifer, what do you think?
Yeah, I think this ties nicely into the next case, which maybe I'll start, but it presents with a similar looking skin lesion. So I thought this would be a nice contrast, except that the skin lesion got worse instead of better. So this is a 62-year-old male patient of mine diagnosed with Parkinson's 12 years ago and started subcutaneous phospholevodopa for motor fluctuations. He did initially start with a 6 millimeter cannula, changing it daily, got comfortable with the procedure and started changing it every 3 days. But overall did really well over a month. And at day 45, developed an area of warmth, erythema, induration, no discharge. We counseled him to just observe the area, warm compress, massage. At that time, we did change to a 9 millimeter cannula, as was suggested previously, and then go back to changing daily. So he was avoiding that site, but over the next 5 days developed a mild fever, and instead of getting better as in the previous case, the area kind of expanded beyond this circumferential mark that he put on his abdomen. So he did go to the emergency, and some studies were performed that demonstrated a little subcutaneous fluid collection, and he received antibiotics and got immediately better. So he's just left with a residual nodule at day 90. So the nodules do persist for quite some time, particularly if the reaction was quite strong. But I thought this was a good illustrative case of a similar appearing skin lesion that had a slightly different outcome.
Yeah, and I think the challenge is, when does the case one become case two? And I personally look at it at any time. Let's say if my patient had called the second day saying that it's getting worse, I may have actually started the patient on oral antibiotics such as doxycycline, because it has both anti-inflammatory and antibiotic properties. And hopefully that would have also worked for this patient, because the longer we wait, that's the risk we end up with, is requiring IV antibiotics, which is extremely rare in my mind. In fact, I don't remember any one of my patients in the time I've been using it requiring IV antibiotics.
Yeah, I agree. We've had patients on these therapies 8 or 9 years now through the development. So it is exceedingly rare. And I think there are two extremes, one that resolved on its own, one that required IV. But typically, I agree with you, Raj. I would use the doxycycline 100 milligrams twice a day for 7 days, because of its anti-inflammatory and also an antibiotic if I was concerned. And to be clear, when I send patients home in a subcutaneous infusion, I give them two things: a prescription for doxycycline, so they have it just in case they call me up and we want to begin it. And I also give them a medication schedule in case we do interrupt the infusion. They have their oral medication schedule to go back to. So that's important as well. The next case is just very briefly to point out that not all infusion site reactions are inflammation or infection. Sometimes it's just a little pooling of the medicine under the skin. Maybe it's not being absorbed for some reason. Maybe it's the habitus or a position of the person, or they have something on their skin, tight clothes or whatnot. And sometimes swelling can reflect drug pooling and not have any inflammation or infection. I don't know if Jennifer or Raj, you have.
Yeah, I would say drug pooling with subcutaneous apomorphine. It is much, much more common with carbidopa, levodopa.
Yeah, and it may reflect the volume being infused as well as viscosity or other physical characteristics of the medication. I agree with that. Let's move to case 4, because the time is moving on, and I think this is an interesting case because this is the most common scenario I think we see with both subcutaneous infusions. This is a 68-year-old gentleman with Parkinson's disease for 9 years. He's on continuous subcutaneous infusion of apomorphine for 7 months now. And he notes at a routine of clinic evaluation that he notes these bumps, these nodules under his skin. He doesn't note it after every day when he takes it off, but some days, maybe one every 3 days, he notices a bump under the skin. It seems to last for a couple of days and then go away. And he wants to know, is this something that is concerning? Should he continue or stop this? Jennifer, what would you do?
Yeah, I mean, I think this nodule formation we see more commonly with subcutaneous apomorphine, and it's generally not concerning. It doesn't interfere with the effectiveness of the therapy. I might suggest some massage with each site, and the question is, how long do these nodules last? And it can be quite variable in my experience. I mean, they can last anywhere for a couple of days, but it can last for weeks at a time as well. Just try to avoid that site for future infusions, just to minimize the reaction that might happen, and some of the logic changes may interfere with the absorption. So certainly rotate sites frequently, and just gentle massage is the way I would treat these.
Great. Any thoughts, Raj?
Yeah, I think the challenge has been Europeans who are much more experienced with the apomorphine infusions have tried different therapies. There's no real good data to say any of these therapies work, except for actual cortisone injections into the nodules, which again we would not routinely recommend in our patients.
Great. Just let me maybe summarize here that infusion site reactions with these new subcutaneous therapies in the US, although the apomorphine subcutaneous infusion has been used for over 30 years in Europe and Asia and Australia, but they're common. But they commonly reflect inflammation, nodules that are asymptomatic. They can be a localized inflammatory response, and occasionally we might wonder, could there be an infection, and use empiric antibiotics. Simple measures may help reduce the incidence of these with good skin hygiene and manual and observation. But if patients are noting these things, they should not discontinue therapy, but let us know so we can help counsel them and evaluate them further, because most of these are going to be mild, self-limited, and able to be managed routinely by the treating neurologist. Great. Well, very informative. I enjoyed presenting together with Dr. Power and Dr. Huey. For those who listened in, hopefully you found it informative as well. But thank you all for joining us, and hopefully you'll find this helpful for your patients. Thank you again.